Hello, everyone, and welcome to our first online ethics webinar, which we have coined the term Athena. We hope this is going to be the first of many Athenas that we will organize under the organization of the Asian Pediatric Ethics Network. So this network was formed last year during our first inaugural Asian Pediatric Ethics Conference held in Singapore last year in last October. The idea is to connect and create a platform for ethicists and clinical practitioners who are interested in pediatric ethics to come together, share best practices, and support and each other and collaborate as well. So at the end of this, we're going to have a QR code. If you are interested to put yourself onto the mailing list or to join the APEN, please do so. We are going to have our second Asian Pediatric Ethics Conference to be held in Singapore this coming November, 6th and 7th November this year. So please do indicate your interest if you are interested. And we are hoping to bring this conference to the other countries in Asia as well. So today we have a distinguished panel of speakers to talk on the theme of adolescent sexuality and ethical issues. We have Dr. Jagdish Chinappa, who is going to present a case from which the talks are going to be around. We also have Miss Hilary Chua, which I'll introduce later, Dr. Subatra Jayaraj, as well as Dr. Jacinta Tan, which I'll introduce later. So first up will be Dr. Jagdish Chinappa. He is a medical practitioner in India from Bangalore. He got his MBBS in the Grand Medical College and Sir J.J. Hospital in Mumbai. He is also certified in pediatric bioethics from the Mercy Children's Hospital in Kansas in 2015. He has a wide interest in pulmonary medicine, ethics, as well as ethics, neonatology, psychology, and as well as IT. So he has a lot of experience in dealing with ethical dilemmas in his practice, and he has brought his case to this webinar, Athena, where we will talk around. So without further ado, can I invite Jagdish to talk about your case?
Thank you. Thank you for that very kind introduction, Dr. Chan, and all the members of the APN community who are here today and respected speakers of the day. I think we have chosen a very important topic for discussion as our first Athena. This topic has got widespread implications from the medical community, from the morality point of view, from socio-cultural aspects, from the economic aspects, from the legal aspects, from the psychological aspects, from religious aspects, developmental and protection aspects, the police involvement, and the educational aspects. So I think this Athena was chosen as our first Athena primarily because it has so many implications in our practice. So I am going to talk about a case. This is actually encounters that we have in practice, but it does not pertain to any one patient. And therefore, we do not need to take any consent on presenting this case. This is a child F, a 14-year-old girl who is a regular patient from birth, visits the consulting room alone without anybody with her. Her parents are divorced and she stays with her mother and grandmother. The mother is a lecturer and F is a student in school. She would like to speak to you in private and request that the chaperone be sent out. In India, while examining a girl child, a chaperone is a must. And somebody has to be along with the child in the room. Next slide, please. You refuse to send the chaperone out, but send her to a corner where the chaperone can see you but not hear the interaction. F confides that she is going out with friends whom she met on a social media site and requests a prescription for contraception. She requests confidentiality and asks you not to speak to her mother or grandmother about her request. Next. Now the problem in our country is, what should you do in her best interest? Should you provide her with a prescription for a contraceptive? Should you inform her mother or grandmother? Or is there any need for informing the law enforcement or the child protection agencies in our country? So this would be the topic which we would first address. Next. So let's have a poll amongst all the attending people on three things. Would you provide prescription for the contraceptive? You have three choices. Please choose any one of them. Should you inform her mother? Choose any one of them. And if statutory rape is 14 years and below, is there a need to inform the police? Again, you have three choices. So please vote. Let me also remind you that we will be revisiting this later in the presentation. So please go through this and answer in the next 3 to 4 minutes. Thank you.
So you can continue voting for the poll. We will show the results at the end of this talk, which is to be given by Hilary Chua, as to how the laws relating to adolescent sexuality and reproductive rights vary in Asian countries. Her talk is on the sexually active teenager and the law and overview. Hilary is a lawyer, obviously. She graduated with a Bachelor of Laws with First Class Honours in King's College, London, and she's currently the Sheridan Fellow in the National University of Singapore, the Law Faculty. She is now currently pursuing a Doctor of Philosophy in Law in the University of Oxford. Hilary has an interest in medical bioethics and has also obtained a Master's of Bioethics from Harvard Medical School. And she's won a lot of prizes. Her pet topic is on disability law pertaining to people with disabilities. So she will be talking, her talk will be on the sexually active teenager and the law and overview. So I'll hand over to Hilary.
Thank you, Mayok, for the kind introduction. Let me just pull up my slides. Okay. Are you able to see my slides? Okay, great. So yeah, as Mayok mentioned, I'm Hilary, and I'll be presenting on the topic of the sexually active teenager and the law. I'll be providing an overview of some international legal principles while focusing in on Singapore law, because that's what I'm familiar with, and then also bringing in some insights from Malaysian and English law where relevant. And so I'm particularly interested in this topic as somebody with a background in medical law and ethics. I used to be in legal practice, but as Mayok mentioned, I've since transitioned over to legal academia. So before we dive into the topic for today, there's one important point that I would like to highlight, which is that laws differ by jurisdiction. In other words, the laws that apply in one country may not be directly applicable or represent the rules in another. So
Sorry, you seem to have you've been cut off.
Yeah. Sorry, I think I accidentally dropped out of the call. Let me start sharing my screen again. Some internet issues. You know what? Yes. So continuing on, as I mentioned, laws differ by jurisdiction. So this is very important to bear in mind, especially when you're reading medical guidance from a different country, because the medical guidance might be based off the laws in that country, and that might not directly represent the law in your own country. One example of that is when reading the General Medical Council guidance from the UK, where it might mention that Gaelic competence applies to minors below the age of 16, and that there's a presumption that minors aged 16 and above are competent to consent to treatment. Now, that's a rule that exists in the UK because of a specific statute, which is Section 8 of the Family Law Reform Act. But when we think about that in the Singapore context, there's no equivalent legal rule in Singapore, and therefore that rule doesn't directly apply locally. And similarly, when reading the American Academy of Pediatrics guidance, it will talk about the mature minor doctrine and this idea of emancipated minors, where there's specific rules by states about how minors can gain emancipation from their parents. But those rules tend to be quite specific to different US states and may not be directly translatable to other contexts. Because of this principle, it also means that I'm not able to cover in depth all the laws of all the countries represented in the audience here today. But what I will do is try and highlight some international legal principles that apply across different countries and present some important legal considerations to think about when treating the sexually active minor. I'll also be focusing in more on Singapore law and laws pertaining to the common law jurisdictions, so the countries in red on this map. But if you're not from those jurisdictions, as I mentioned, I'll also be talking about international legal principles. Okay, so on to my next slide. Yes, so these are some of the topics that I'll be covering in my talk. I'll start first with the age of majority, which is the boundary between two legal frameworks for medical decision-making and consent. So this is a legal fiction that sets a bright dividing line between who counts as an adult versus who counts as a child in the eyes of the law. And we can see that this is a legal fiction because the age of majority actually differs across countries. So we can see from this table that in most countries and territories, the age of majority is set at 18, but in places like Singapore and Korea, it's set higher at 21 from common law and 19 respectively. So actually in some of the other territories and countries represented here, like Hong Kong, Malaysia, and the Philippines, it used to be set at 21, but then legislation was enacted to bring it down to 18. So I'd like to draw your attention to the first line in this table, which is about the UN Convention on the Rights of the Child. So that's an international treaty that sets down principles about child rights that apply to most countries around the world. That's because all UN member states have signed this treaty except for the United States. And under the CRC, as I'll be calling it, a child is defined as someone below the age of 18 or younger if national legislation provides for minors to attain majority earlier on. So I'll now be turning to some general legal principles from the CRC. There are three principles that I'd like to highlight today. The first of these is parental responsibility. And the core idea here is that parents and guardians have the legal authority to usually decide and give consent on behalf of children who are below the age of majority. So this idea might be framed slightly differently depending on what country you're from. So for example, in Singapore, under the Women's Charter, this is defined as the duty of parents to cooperate with one another in caring and providing for children. Whereas in the English context, under the Children Act, it's defined as all the rights, responsibilities, and duties which by law a parent of a child has in relation to the child and his property. But the core idea is that by default, usually parents and guardians can give consent on behalf of children. And I'd like to draw a distinction here between consent and assent. So for consent, that is something that has legal effect. It's an agreement to receive treatment and that has legal effect. And that can be contrasted with assent, where children usually agree to treatment, but that usually doesn't have legal effect unless special rules apply. The next principle I'd like to highlight is that of best interests, which is a foundational principle in child law. So under Article 3.1 of the CRC, it states that in all actions affecting children, the child's best interest shall be a primary consideration. And that might be framed slightly differently in local statutes and cases. So for example, in the Singapore Guardianship of Infants Act, it's framed as the welfare of the child being the first and paramount consideration. And similarly, in the Malaysian Guardianship of Infants Act, it talks about how a court or a judge should have primarily regard to the welfare of the child, where welfare is used interchangeably with best interests. And in order to assess a child's best interests, it's important to consider all the medical and non-medical factors affecting the child. So that includes emotional, psychological, and religious factors, weighing them all together in order to decide what is in the child's best interests. And the next important principle that I'd like to highlight is respecting the autonomy of developing minors. So under Article 12.1 of the CRC, it says, assure to children who are capable of forming their own views the right to express those views freely in all matters affecting them, their views being given due weight in accordance with their age and maturity. So in other words, as a child grows and develops in maturity, the more you give effect to their views, the more you listen to them and involve them in decision-making. So as you'll notice, in cases of conflict or when a sexually active minor presents in your clinic and requests treatment without parental involvement, some of these principles start to come into tension with one another. And that's why it's important to then look at other legal rules to decide how to resolve those tensions. And I'll be discussing some of them today. So the next thing I want to talk about is how the law treats adults and minors differently and has different rules for when adults can consent to treatment versus when minors can give consent to treatment. So I've included this quote here by Dr. Vic Larcher. He is a pediatric consultant from the UK, and he states that children are not small adults. And he's saying this in relation to children's cognitive development and also medical ethics, but it's also a principle that's quite relevant to the law as well. So in this slide, I've presented some legal rules. These are mainly drawn from Singapore and English law, but I think that they can be quite applicable in other countries. These are for illustration. As we can see, for adults, the starting point in the law is that they are presumed to have capacity. So a patient with capacity can give their own consent to treatment if they are of adult years. So in other words, above the age of majority. And there are also requirements that the consent must be voluntary. In other words, free from duress and undue influence, and it must be informed. So providing the patient with relevant and material information in order to make a decision. And that's a different starting point from minors, where usually the law presumes that parents and guardians have the authority to give consent on behalf of the child. So turning back to adults, what are some of the consequences of having capacity? One of those consequences is a right to refuse treatment at risk to their own health. And only if an adult is assessed to lack capacity, for example, because they can't or are unable to make a decision because of an impairment in the functioning of the mind or brain, then the best interest standard applies. Right? So we start from a presumption that we respect adults' autonomy. Only if they lack mental capacity, then we start to apply the best interest standard, which also takes into account all the factors affecting them and their wishes and feelings. Meanwhile, let's look back at the minors. So we start with a presumption that parents and guardians give consent and that best interests applies by default because of that principle in the CRC about best interests of the child being the primary consideration. And the child has a right to be heard and involved in discussions to an extent that measures up to their age and maturity. However, exceptionally, there are some laws which allow mature minors to give consent to treatment. So this can either be consent from the child alone or consent from the child together with a parent and guardian. And that's usually required in more serious types of treatment, like treatment for childhood gender dysphoria or sterilization, for example. So we'll be looking at some of those laws that exceptionally recognize the right of minors to give consent in my next slide. So I'll be talking about Gillick competence. So this is a concept that originated from a House of Lords decision in England and Wales. So it applies in the English context, and some common law jurisdictions have adopted it, although it doesn't apply across the board to all countries. So I understand that Australia has adopted this. In Singapore, we recently had a case that mentioned this. And for other common law jurisdictions, I'm not sure, but it can be a potential guideline for how to approach these decisions. So this case concerned whether or not minors have a right to consent to receiving contraceptive advice and treatment without the involvement of their parents. And the House of Lords decided that, yes, minors do have such a right when they have achieved a certain level of maturity and competence to do so. However, there were two main decisions within the judgment that were handed down, one by Lord Scarman and one by Lord Fraser, and they emphasized slightly different points. So starting first with Lord Scarman, he stated that minors with sufficient understanding and intelligence to understand fully what is proposed can give their own consent to contraceptive advice and treatment without parents' knowledge or involvement. And Lord Fraser expanded upon that idea by laying down these 5 criteria, where he said that you can treat or advise a patient without parental consent if the girl will understand your advice, you cannot persuade her to inform or let you inform her parents, she's very likely to begin or continue to have sex with or without contraception, unless she receives contraceptive advice or treatment, her physical or mental health are both likely to suffer. And lastly, that her best interests require you to give her contraceptive advice, treatment, or both without parental consent. So I've put the term best interests in bold because I think this emphasizes an important point that the law regards minors differently from adults. Because for adults, best interest only applies if they're assessed to lack mental capacity. But here it seems that for children, best interest still is a relevant consideration operating in the minds of the judges and also of doctors when thinking about how to treat a competent patient. So an example of how that 5th and last principle might operate in practice, thinking about whether or not the child should be treated without parental consent in her best interests, that might be because treating the child without parental involvement might promote health-seeking behavior so that the child doesn't end up going to unlicensed or unreliable sources of information to receive that advice instead. So one of the more controversial aspects of the Gillick decision is that Lord Scarman said that parental rights terminate once a child achieves competence. So the question I'd like to pose is, do parental rights really terminate when a child achieves competence? And my answer to this question is probably not, because when we read subsequent cases that have discussed Gillick competence, we see that the courts in England and Wales, Canada, Australia, and New Zealand have all held that children's refusals of treatment, especially when that has significant consequences to health or is life-threatening, can be overridden by a court order or by seeking consent from the parents to the treatment instead. So there's this idea that parental rights still exist in the background, or you still have to think about whether or not to involve parents or whether involving parents would or would not serve the child's best interests. And I like the way that my family law professor, Professor Stephen Gilmore, put it, where he said that competence depends on a finding of intellectual ability, emotional maturity, and that the parent's protective role can be safely abandoned in circumstances. So these are some things to bear in mind when deciding whether or not to treat a child without their parents' knowledge or involvement. And other cases have emphasized that it's up to doctors to assess the child's individual competence for particular decisions. So the next thing to consider is, when does Gillick competence apply? So because the case was about contraceptive advice and treatment, it applies there. And it also applies to other areas that are not governed by statutes and regulations. So as I'll be talking about next, in some countries, there are specific statutes about consent by minors to particular forms of medical treatment. And if those rules and regulations exist, it's really important for you to look to those statutes first for the relevant rule and apply that instead. Okay. So to illustrate, I'll be talking about some of these statutory age thresholds that exist within Singapore law. These are some exceptions. Yes. So within the Singapore context, we have statutes on a whole bunch of issues. One of them is on the Termination of Pregnancy Act, where we have very liberal abortion laws that say that there's no age restriction for consent to abortion up to 24 weeks. And that's quite different from other countries, such as Malaysia and India, where the rule is more strict. So within Singapore's Termination of Pregnancy Act, for any girl or minor that presents in a clinic requesting for abortion, there is no need to involve parents or to seek consent from parents. You can seek consent directly from the child. However, if we look at the prescribed consent form in the regulations, the minor must still understand the procedure, and that's where some ideas of Gillick competence might be relevant here to assess the child's understanding. And there's also a requirement for mandatory pre-abortion counseling regardless of age. And then there's also a specific statute on sterilization. So under the Voluntary Sterilization Act, married minors can consent to sterilization. Unmarried minors, they need review by a clinical ethics committee, and consent must be obtained from both the child and a parent and guardian. Meanwhile, for minors who lack capacity, such as minors with intellectual disabilities, in order to lawfully perform a sterilization procedure, you must obtain a court order in best interest before you can proceed. There are also other statutory age thresholds in a whole bunch of statutes on safeguarding children and vulnerable adults, where vulnerable adult is defined as starting from 18. Then for commercial contracts under the Civil Law Act, persons aged 18 and above can give consent. And for advanced directives, you need to be 21 and above in order to make one. So as you can see, the age thresholds do actually vary depending on activity, depending if it's regulated by a specific statute. So that's something important to bear in mind. And if you're not sure about what those are, it's good to seek legal advice. And if you're from other jurisdictions, I would also encourage you to seek legal advice to just understand whether or not there are specific statutes to be aware of. Okay, so the last thing that I'm going to talk about is the duty to report crimes, especially if a sexual offense has been committed or if the child is below the age for sexual activity. So I'm going to highlight 3 key principles to try and bear in mind in this area. The first of these is the need to be aware of what the sexual offenses are in your jurisdiction and what the legal reporting requirements are. So for example, in the Singapore context, in the Penal Code, statutory rape is defined as sex with or without consent with a minor who is below the age of 14. There's a separate offense of sex with a minor below 16 and exploitative sex with a minor who is 16 or above but below 18. And there are also separate offenses on commercial sex with a minor under the Women's Charter. And in Singapore, under Section 424 of the Criminal Procedure Code, there's actually a legal requirement to report the sexual offenses. And this says that unless you have a reasonable excuse where you have the burden of proof of showing that reasonable excuse, you must report the commission of these offenses. And we can look at the other side of this pie chart, which talks about the duty of confidentiality and exceptions. So we know that doctors owe a duty of confidentiality to patients, including patients who are minors. But there are recognized exceptions to this, and a legal duty to report offenses would be one of them. However, this can create some tensions in practice, especially if reporting the offense might cause some harm or distress to the minor. For example, if the perpetrator is somebody that's really close to the minor or is a relative in cases of incest. And so in these situations, it's also important to consider whether or not there's prosecutorial discretion and what the child's best interests are. So, for example, if reporting the crime would cause some distress to the child, it's important to counsel the patient about this requirement to report the offense and to involve medical social workers to deal with the psychosocial aspects and also to seek legal advice about what can be done. So in the Singapore context, it's a little bit unclear when or whether the police and prosecutors will exercise discretion to not prosecute an offense in a case where doing so might harm the child. So again, this is an area where it's important to seek out legal advice if you're facing this specific issue in your practice. And of course, if you're from other jurisdictions, it's really important to understand what the sexual offenses are and whether or not there's a legal reporting requirement. For example, I understand in Malaysia, statutory rape is defined as sex with someone below the age of 16. So again, there's some different age thresholds to bear in mind. So with that, thank you very much for listening to my talk. And if you have any questions, feel free to ask them. I've also included some resources in my slides in case you want to find out more. Thank you very much.
You who think that you might have not gotten the right answer, that you would get the right answer. Okay. Okay. So, sorry, I realized I did not introduce myself earlier. My name is Chan Mei Yok. I'm a pediatric hematologist, oncologist from the KK Women's and Children's Hospital in Singapore. And I'm also an adjunct associate professor in the Center for Biomedical Ethics in National University of Singapore. So now that we have gotten one talk done, I will hand back to Jagdish again to continue the story. So let me just share screen. Right.
Thank you very much, Ms. Hillary, for that excellent overview on the sexually active teenager and the law. I think it was very insightful to hear about all the international guidelines on how this is handled in different countries. Now, to continue with our case, F is not prescribed contraception. She returns after 6 months with severe pain and abdomen with nausea and vomiting. She has missed her periods and has not informed her family. She's 24 weeks pregnant and scared. She asks you for advice. Next slide. What are ethically reasonable options here? What should be your advice if the partner is a classmate who is also maybe around 16 years, or if the partner is a 28-year-old music teacher? Does it differ in the ethical issues? Can we now move ahead to the next slide? So now let's have a poll. So what are the ethically reasonable options for F? 1, abortion. 2, continue with the pregnancy. 3, inform parents and let them decide. 4, inform partner and involve him in decision making. This is the first one. And the second one, would your action be the same for the classmate and the music teacher? So you can vote now.
Okay, so while you are mulling over the question and voting, basically, the case now asks questions. What are some ethical issues arising from the adolescent sexuality, contraception, pregnancy, and termination? And to hopefully answer this question, we have Dr. Subatra Jayaraj, who is going to give the next talk on ethical issues arising from adolescent sexuality, contraception, pregnancy, and termination. So Suba is a medical doctor who graduated with honours in medicine from the National University of Ireland. She also has a keen interest in sexual and reproductive health and has a Master of Medicine in Sexual and Reproductive Health from the University of Sydney. She is currently a primary care reproductive health specialist in the clinic Rakyat PJ in Selangor in Malaysia. And she has her CV has a lot of activities that she has done that led her to advocate for reproductive and sexual health matters in women. So she would be the ideal person to give us the next talk. So I'll hand over to Suba.
Thank you very much, Mayok. I'll just share my screen now. All right. So we're good? Okay, thank you very much again.
Suba, I think
Yep.
it is on the presenters mode.
All right. So I
Maybe you yeah.
share again. Yeah.
Yeah.
Hang on. Is it this one? Hang on. Yep.
Yes, perfect.
But it doesn't.
So then now
Oh,
our
okay.
screen-
Yeah.
Yeah,
All right.
that's right.
Okay, let's just try this again. Okay. Is this okay?
Yes, perfect.
Yeah. Okay. Thank you very much, Mayok, for that introduction. And I think the most succinct thing you said is that I'm the perfect person to say that there is no right answer for any of the questions we've asked today. As practitioners and clinicians, especially working in sexual reproductive health, we see a breadth of issues and frequently, especially in sexuality and more so in adolescent sexuality, we are conflicted at loads of times. And it's good. If you don't feel any conflict, I think, you're not really having a clear understanding of the entire issue. So I'm here to share, at least from a clinician's perspective. I'm a primary care reproductive health specialist, so I provide contraception and termination of pregnancy services in Malaysia. And I work also within advocacy in Asia. I'm the chairperson of the Asia Safe Abortion Partnership. So we are cognizant that we work in a diverse environment with many regulations, many laws. Hillary's tried to just give us an overview, but I think eventually our job as clinicians will be to understand the laws and situate our clinical position within ethics, laws, and our service provision. So I'm just going to touch a little bit on the issues. I wouldn't say there's answers, correct answers, because answers are a developing process as it is. So when we talk about ethics, I'm sure many of us probably are familiar with the 4-principle framework of ethics. Just to structure the conversations and arguments on how we articulate our arguments over why we think one is right over the other, but particularly because ethics govern how we provide clinical service. And we know autonomy. So autonomy is very important in sexual and reproductive health. It's the respect and support for individuals to make free and informed decisions. And we respect their ability, especially as Hilary explained just now, in every individual. When we talk about non-maleficence, it's the do no harm principle in essence. It's the obligation to not cause more harm. But then again, harm for different people are different, and especially in sexual and reproductive health, a choice of harm against benefit it's also a choice. And frequently a choice that is conflicted, but ultimately from a rights perspective, it's as an adult, we give that choice to the person itself, to our clients. But as a child, there are many other issues. When we talk about justice, we attempt to distribute the benefits and the burden. So justice requires us to understand not only the medical position, not only the examination and the history, but the entire context in which the client's life is from. So principalism is also one of these issues that we talk about. Principalism encourages us to interrogate these 4 principles and understand that there definitely is a tension involved, and you should balance and choose as needed. So particularly in bioethics, we try to articulate the root of potential ethical conflicts that occur when we see clients in clinical practice. One of the issues that always comes to mind with adolescents is the capacity to consent. Hilary covered the legal aspects of it, but for as a clinician, yes, we kind of have to know and assess. But assessing capacity has a whole host of different facets as well. Frequently, we use age as a surrogate because it's the easiest. It has legal backing and it's standardization. And unfortunately or fortunately, lots of clinicians just use the law to have a final and easy way discussion. But in my practice, definitely, I see at least one minor a week in my sexual and reproductive health for termination of pregnancies or contraception. And using just age as a surrogate, I would say is the easy way out because we recognize that it's a socially arbitrary age, right? We see even in my clinical practice over 15 years, you've seen how children develop, interrogate their own knowledge, and actually implement decisions for their lives. In Asia Pacific, the age of consent and age of majority is there is a difference as well. So it's very difficult for us when we use age of majority. In Malaysia, where I practice, is 18, but then the age of consent is 16. So there is a gap in how and where we can situate ourselves and make our decisions, and it's not straightforward. For example, in Malaysia, if you are married as a child, so child marriages have different definitions as well. But just if you are married at 13 to a 12-year-old, you have different consent abilities compared to a 14-year-old, as we saw in that case study. And the 13-year-old can give consent for the 12-year-old. So it's really arbitrary if you use an age as a surrogate default, right? So my argument would be ethically to assess whether we can use capacity by assessing the adolescent's capacity to understand and make informed decisions. And this is also a skill, definitely, on how we do this. And but unfortunately, it lets us, not have a really good legal argument against it. It's difficult to prove it in a court of law. Argument on capacity, on assessments on capacity varies. Different points of maturity. Definitely, if you see a client in a month, it's a different age, and there's so many things happen. So every client is always in a different point of maturity, so that adds to the dynamics. Finally, in assessing adolescents' consent, we have to understand that we have to recognize that there's a lot of power dynamics between us as service providers, between the clients, between the parents and guardians, and also involving the state. So if you involve the state in assessing capacity, there is so much of a power differential that we really need to assess that it is putting the child at the center of all our decision makings. So with that, knowing that it is difficult, I'd just like to share a framework here. This is a position paper from the European Academy of Paediatrics, and they suggest a framework on how to approach and take care of a minor adolescent in situations of ethical dilemmas. Definitely, it takes a lot of exploration. It is not only the medical perspective, it's a social cultural aspects in many of the places that we work in, particularly where definitely, even if there are laws, there is no social support. So child protectors, even they are there on paper, they're not easily accessible. Parents, in practice, parents are given the responsibility of parenting. If you ask a client, if you see clients, you might not consider the parental judgment the best. So questions on understanding whether the parental decision is actually the best interest of the child comes up a lot. So we need to really get a good understanding. So really explore the situations the client is in, make a decision, and then continue following up because it's a dynamic process. Hilary covered Gillick competence and so that's the whether a child can consent to medical treatment, right? If the child does not have a capacity to consent, then the question becomes, can someone with a parental responsibility do so? So these examples are parents, legally appointed guardian, or local authorities. For example, child protectors. Today, I had a 17-year-old who I assessed, wasn't making enough intelligence and competence decision. But by law, she would be able to make decisions for her sexuality and consent, but as under the Child Act in Malaysia, she wouldn't be able to consent. So that was quite a straightforward case. So then, you would need a parental consent. But frequently, it becomes like, who would you call, especially if the parent or guardian puts them in a more vulnerable situation than they already are. Would the parent or guardian expose them to violence? And will reporting it to the police or child protector expose them to more threats? So it's assessing entirely, and not just thinking of who to refer to. But ultimately, competence is an assessment of the individual if they can consent on their own. Fraser guidelines, I just like to state that the Fraser guidelines were specifically for contraception. So when we say Gillick competent, a child can be Gillick competent, but in sexual and reproductive health, we don't only talk about contraception. For example, there's termination, there's just agreement for medical treatment for basic, infections, maybe communicable diseases. When we use Fraser guidelines, what it outlines is specific to contraception. So the Gillick competence and Fraser guidelines also remain to be tested in most countries. In Malaysia, it's not been tested yet. So we do kind of tend to have to fall back on common law. In my workshops, when doctors ask me, I would provide contraception to minors if they are Gillick competent. But frequently it becomes like, will the law protect you? So we know if you use Fraser guidelines and you document it properly, there might be a higher chance for you to be protected by law, but it has never been tested in my country. So it takes, lots of doctors are hesitant and then eventually not providing services that is to the best interest of the child. The next issue in sexual and reproductive health we talk about is safeguarding. Safeguarding is always an ethical dilemma when patients come in. If they're GILIC competent, should we escalate it as well? So in the case of the 14-year-old child, should we escalate concerns in safeguarding to social workers, child protectors, child protection services? We know that we should. There are guidelines, but ultimately it's the clinician's assessment together with the child, putting the child at the center of all decisions. If they aren't GILIC competent, then the healthcare professional is obliged to escalate through safeguarding measures. So again, the question of would the child be aware of this, and would escalating to safeguarding measures either cause significant risk to their safety or not? Because frequently, theoretically, it does protect them, but it will also cause substantial harm. And frequently in sexual and reproductive health, it's a balance between a little bit of harm and a lot of harm. So safeguarding measures probably need to be improved in practical terms, not only in documentation, as currently it stands in many of our countries. So the issue of the best interest of the child, in paper, it's very easy to say, yes, it's the best interest of the child. For example, escalating it and informing parents of concerns. But of course, there's a lot of situations where escalation are not in the best interest of the young person. It's easier when it's an opt-in situation, such as contraception, where you would say, yes, I'm not doing any harm by changing the status quo, so I'm not going. But in cases of refusal of treatment, then it becomes a little bit more complicated. I think Hilary will have a little bit of discussion there. In cases of refusal of treatment, a lot has been documented in research as well, because this can be either overridden by court, in a court, or somebody who has parental responsibility. Frequently, we see a lot of the legal challenges being around refusal of treatment. I see lots of young people in sexual and reproductive health request, but very few are like, we think of GILIC's competence in Fraser guidelines a lot. But a lot, I would say lots of patients actually can access services without problems, and there has never been that many legal challenges to accessing contraception, for example, or as much as refusal to treatment. And then talking about the best interests of the child, for example, can you trust the parent to have the best interests of the child at all the times? I've had parents who come and request for IUDs, intrauterine devices, for children who have intellectual disabilities, for example. And the reason for the request was because the parent was aware that there was a threat for sexual abuse or sexual harassment going on by the neighbor. So she was worried that her child with an intellectual disability would eventually become pregnant. So in her thinking, her best interest is to protect the child by sort of forcing the child to get an IUD before anything happens. So, sometimes it's really articulating what is the best interest of the child. And we see cases like this all the time where the parent's decision might not necessarily be ultimately the best interest of the child. We have cases now where in cases of incest, where one parent decides to stay with the perpetrator and not make reports. And the situation of violence keeps going on because the social structure of the police and the follow-up with the child protectors are not really working. And the parents keep making decisions in which we think it's not in the best interest of the child. And the state system seems to protect the parent, right? So this is the kind of arguments that we can really see where the doctor's decision kind of really needs to advocate on what is putting the child's well-being the first as the most important. Another issue which always comes up is confidentiality. So just thinking about confidentiality and talking about bringing up this issue of confidentiality with the client, right? So my question to participants here today is, do you bring up the issue of confidentiality with your adolescent clients before consultations, during consultations, or after consultations? Because bringing up it different phases really changes the way that we actually see clients. It changes the amount of information that your clients might actually give you, and it totally changes the management of how you would proceed. So should a parent or guardian be involved from the very beginning of the consultation, right? And just to think in your clinical practice, which part and which phase do you bring in a legal guardian or legal a protector in a first consultation that you're seeing a client? Do we give the child full disclosure on who will be involved and who will have access to this information? Do we give them especially a breakdown? For example, are they just going to be telling their story in front of a chaperone, or do they have to tell the story in front of a parent? Or if you tell me as a doctor, I am obliged at certain times to break confidentiality with a child protector or police. And frequently, when we work with systems of public health, with social welfare and an example outside the medical system, such as notification of diseases, how much do we actually tell young people the extent in which we might tend to break confidentiality? And just to throw it out, like how would informing clients at various steps affect the service provision and full disclosure on their part? Because if you let them know early on, they might not even let you know and give you a good history, which is very important in sexual reproductive health. Hillary covered a little bit of duty to report. These are mandatory reporting and always put us in ethical dilemmas. It's very easy when there is known and reasonably suspected child abuse, neglect, child sexual abuse, pornography. That's very easy. But unfortunately, we work in a huge gray area where sexual abuse definitions are gray because they now we have relationships starting at very early age. In Malaysia, 33% of children are sexually active, and this includes children less than 14 years of age. So how are children coming to us as healthcare providers, understanding that, getting the trust that we have a duty to report, but we know that we cannot report all cases, and where do we kind of find the balance? It's easy if there are certain guidelines by law. For example, in Singapore, there's different definitions, and you can see how the age definition has come down from 16 for consent to a 14-year-old difference in the law as well. So it's an ongoing dynamic change in the law because of how we see and how we are practicing in these gray areas. Ultimately, I think physicians that see adolescent clients for sexual and reproductive health, our job is to explain to clients that their discussions are confidential, unless given the client themselves gives us permission to disclose, and there's a concern for serious harm to the patient. So this is what I tell all my clients from the very beginning, so that they can understand, and then they can put they can make a decision. But of course, there's a lot of trust building and rapport that needs to be done as well. Ultimately, I think physicians should not give, you can never say, I will promise not to tell anybody. That's putting us in very ethical dilemmas as well. But the CRC has supported doctors in many ways. And despite the laws, I think there have been many judgments which contribute to understanding that sufficiently mature adolescents can request for care. And that includes contraception, abortions, and sexually transmitted infections, and whether parents should be told. So there are legal bases to it, but I'd advise you to go back to your own countries and see how far you can push the boundaries that we do all the time. Another issue in sexual and reproductive health and ethics is always having in the back of your mind the possibility of coercion and grooming, regardless of the age of consent, especially in the context of the power, distance, and dynamics. Even if they're capable of giving consent above the age of 16, but more and more in the age of social media, there's anonymity, there's catfishing, online socializing in so many ways. So coercion and grooming needs to be in the back of your mind, especially in this case that we were talking about. If they have met online, you might have to just explore a little bit more. But understanding the ethics and the non-judgmental way that we have to do things. Definitely, it's not only social media. There's non-online relationships such as the family and child, teacher and students, coach and players, religious leaders and disciples. And to understand that there's a whole host of social aspects that need to be taken into account in dealing with children when they come in with their sexual and reproductive health issues. So when it comes to statutory rape definitions, it's a gray area for clinicians, always in these Romeo and Juliet clauses when a 12-year-old and a 13-year-old are having relationships, right? When a 13-year-old and a 14-year-old are having relationships, and it's especially difficult when it's a 15-year-old and a 15-year-old, for example, and then it is statutory rape. So it is a very conflicting ethical dilemma that lots of doctors are put in, whether they have a duty to report. So many countries are coming up with Romeo and Juliet clauses to take into account these kind of not so large gap in age. But having said that, I see clients who are 17 with 41-year-old partners. And yes, it's always an assessment. It's always putting the child and understanding that they have an understanding of the power, distance, and dynamics, and making the best decision, putting the interest in the child in the center. Another issue for sexual and reproductive health ethically is always around consent to invasive procedures. For example, this case highlights a termination of pregnancy at 24 weeks. For contraception, there has been increased general agreement that it's permissible to get contraception first without parental consent. But for invasive procedures, it's a little bit more gray. Unlike other contraceptives, LARCs, which are long-acting reversible contraceptions, the IUDs or implants, they recommend it to put in when you're 16-year-old and above. It's super, super effective. The CHOICES study, which is a really large study, showed that it is really good in preventing unintended pregnancies, preventing morbidity and mortality, and actually changing lives of teenagers, the life course approach. So, but these are, even though they're really good and should be used and should be offered, they come with a little bit of procedural risk, right? But there have been research and arguments that show that The invasive nature of small LARC procedures do not override the adolescent's ability to make a decision, right? If they want a safe and effective form of contraception. So because they use the argument that LARCs may be in the best interest of the adolescent patient to prevent an unintended pregnancy. But the question is now, and the ethical dilemma and reasoning is that, can we use the same ethical reasoning in permitting adolescents to use LARCs, for example, compared to emergency and pregnancy termination procedures? So it's interesting to hear Hilary say that the termination of pregnancy in Singapore does not have a lower age, but it gives each procedure an ethical dilemma as well. I'd just like to talk a little bit about conscientious provision as an issue as well. When we talk about conscientious objection, that's commonly discussed. Lots of doctors are more comfortable when saying, no, I will not provide contraception for this child. And especially if it's around contraception and abortion medical procedures. But I think ultimately that's fine. Conscientious objection is a right of a service provider, but all clinicians should learn what scope of their services are and what their client feels is morally acceptable. And if their client feels it's morally acceptable, to ensure the clients have information and access that suits their relevant moral framework, which means if they would like a termination, you as a clinician should refer the client to a service provider and give them enough information. So that's in the context of conscientious objection. But in the context of conscientious provision, I think it's equally important, and it's not spoken about a lot. I'm a safe abortion service provider. We provide contraception and abortion because we conclude that the services are morally acceptable. And in a secular ethics position, we conclude that abortion is morally good. So remember I said initially that we need to try to articulate the root, right, of ethical conflicts. So when we provide this, me as a safe abortion provider, I provide abortions, but I honor these 4 principles as well. Yeah. I honor autonomy because it's helping the clients preserve bodily integrity, their decisional freedom and the dignity over their life, and not just in this point of time. To benefit the patient, I'm preventing harms of forced childbearing and unsafe abortion. Yeah. And it's also sometimes an expression of love to current children, bearing in mind 60% of those who request terminations already have 1 child. In the do no harm principle, this is frequently brought up in those that conscientiously object. Yeah. But the do no harm principle and non-maleficence in those who provide terminations, that argument rejects the potentiality argument of fetus. So this is substantial identity. It gives the woman, who is rational and sentient and biologically independent, it gives the woman a higher moral status than a biologically dependent embryo or fetus. So this is the do no harm articulation argument that is put out by abortion providers. And finally, justice. Justice is so important. And I can articulate 2 perspectives, one in terms of economic and social justice. In just a whole essay, I can say just 3 words: parenthood is expensive. So most clients would come in and have this argument, and it's totally fine. For gender justice is really important as well, because we understand what the legal and social discriminations that come with pregnancy have. So this is an example of articulating your ethical principles that govern how you present and you provide services in sexual and reproductive health. I would just like to finally nearly end with this concept of reproductive justice. Yeah. And we all know reproductive rights. Yeah. It's the right of any individual to choose if, when, and how many children they'd like to have, and to be given access to healthcare and information on this. But that's just rights, right? And that rights is a focus on the individual choice. And what we realize working especially in this part of the world or working with the breadth of society is that nobody makes choice in a vacuum. So, which is why I'm a reproductive justice advocate, and we use this framework that connects rights and reproductive rights to analysis of power, structural inequalities, the social and historical cultural discrimination, and the capability of choice. And which I know when a client comes and requests a service, she's not making her choice without taking into account only her life, like her body, and medical perspectives. She's thinking of her family, she's thinking of her society, the whole kind of village, to make the decision on her own body. So this encourages us to focus on the needs and rights of most marginalized. And it also, for us as advocates, for us to focus on institutions of knowledge, primarily for us, like the institution of medicine, and how much, we talk about justice in providing access to services, especially in sexual and reproductive health. So the focus of reproductive justice is also on culture and the responsibilities of the state. Finally, I probably know that there are a lot of researchers here. Just to throw in another one issue in reproductive justice, because we know adolescents are a uniquely marginalized subsection of society. And when we think about research, how much do we think about the capacity of consent for research in a minor, and whether they are being involved in our research? It's so important for their voices to be included. But how? Because the capacity consent is not only for services, but it's also to, be involved in the development of their own, of things that affect their own healthcare. So I'd just like to throw out to you that how does your understanding of your concept of reproductive justice change the analysis of reproductive ethics? Because there is so many gray areas, but we need to ground our ethics in arguments that ultimately put the child at center and put a justice framework as well. Finally, just to end, it's a lot. I know I'm just trying to touch a little bit of the issues that we deal with on a daily basis. This book I thought was really interesting. It's from Julie Chua and Katie Watson. It's more of a global north a group of essays of service providers like me who provide services in really gray areas and continue to push boundaries. It's a lot about law from the US perspective, but other than that, I would encourage you to go to the Asia Safe Abortion Partnership. There's a lot of information there for case studies on the Asia Pacific region. Thank you very much.
Thank you, Suba. We will just show the results of the poll now. Okay. It's very interesting looking at the results of the poll. I'm sure Jagdesh also has a lot to say. Okay, so Jagdesh is going to continue now with the case and not with the case, with the some kind of news and articles in our region. Let me just share. Okay, go ahead, Jagdish.
So I think we had a wonderful session on the ethics by Dr. Subatra, and so many new facts for me to ponder on. So I thank her for that wonderful presentation. And now I will come to what happens when contraception is not offered, and we land up with a huge number of underage pregnancies. And I think my state, that is Karnataka, topped the list in the last year. And as you can see here, 28,000 unwanted pregnancies. And this was all in children who are less than 18 years old. So I think there's a big rethink right now on the policies as far as contraception and as far as even the termination of pregnancy is concerned. So now, Dr. Chan, can you take over the situation in Singapore?
Okay, I just want to share two current news articles pertaining to this issue. I'm sure some of you would remember this case where a teen boy was found guilty of impregnating his 15-year-old girlfriend. And not just that, she had the baby and by herself actually. And they together, because obviously they were both scared teenagers. The baby was stillborn, and she actually buried the body in her own garden. So I mean, this whole thing about sexual and reproductive health in teenagers, I mean, if they are not equipped with the knowledge, this is they put themselves at risk of harm by doing things like that. Or you have teenagers who are pregnant and unwed, where the parents, because of also issues with knowledge and issues with cultural differences, where they get into trouble by being kicked out of their family after they refused an abortion. So the next issue that we're going to address is what are the developmental issues to consider when thinking about consent and confidentiality in adolescent reproductive health, what the societal and cultural issues are for us to consider, and how do we apply legal and ethical principles largely derived from a Western secular humanist tradition to our own medical practice in the Asian societal context. And to give this talk on the developmental and cultural aspects of decision-making in adolescent sexual health, we have Dr. Jacinta Tan. Jacinta was from Singapore, and she had her undergraduate medical training in NUS. But since then, she has had a very varied career. She went on to train to become a child and adolescent psychiatrist. She specializes a lot in eating disorder and has done and published a lot on eating disorders. She's also a clinical academic and medical ethicist. And although now she's retired, she is still very active in the field. And so we are very fortunate to have her to talk to us on this very important aspect of adolescent sexual health ethics. So I'll hand over to you.
Hello, thank you very much. I'm going to go into presentation mode. Can you see it properly?
Yes, it's fine.
Okay, great. Okay. Hello, thank you so much for inviting me. And you're probably thinking, oh, for goodness sake, well, it's a child and adolescent psychiatrist doing here. But actually, it's a core part of the job that I have been thinking about working with young people and families for my entire career. And I'm hoping that I might be able to be helpful to you all from that point of view. So I am retired. I was previously a clinical academic medical ethicist and a clinician. I'm not an expert in reproductive health, so if you've got any particular issues you want to raise, please raise them with Suba. My expertise is ethics of consent and capacity, especially in severe mental illness. And what I bring to this talk is expertise in child and adolescent emotional development, the developmental aspects of treatment decision-making, as well as adolescent treatment and systemic family work. So when we talk about development of decision-making, we tend to have this kind of dichotomy where you go from a child to an adult, and the law as well embeds that. So as a child, you have insufficient intellectual understanding, parents provide consent, all treatment is done in best interest of the welfare of the child. And the adult, as Hilary has very helpfully explained, is very much more the individual decision maker. But actually, I would say that for adolescents, you got this in-between kind of stage. And what we know from research is that adolescents have complete intellectual ability required to form and indicate wishes with simplified treatment information from the age of 9 and with adult level treatment information from the age of 14. So 14, that's really relevant to our vignette here. Adolescents obviously are capable of behavioral choices and seeking help. I very much doubt that F or anybody else you see is actually asking parental permission to engage in, to be sexually active, but they're legally still a child. So you have this tension going on. And adolescents do have limited rights as compared to adults. There's an emphasis on best interest. There's an emphasis on child protection. That still remains. But as we know from the legal cases and practice, involvement in decision-making is growing as they are maturing. So all treatment should still be done in the best interest of the welfare of the child, but how we frame that starts changing as they mature. And I'm going to talk very much about that sort of thing because everything else has been really helpfully already said. So the thing within person factors I want to talk about when talking about capacity, which is actually decision-making capability, is generally speaking, unless you're talking about intellectual disability, intellectual understanding is very good when you see an adolescent, but it's not the same as being able to weigh up various options and particularly think about potential consequences, and even more particularly, being able to take responsibility for the outcomes as an individual. Because the young person is often still dependent within the family and they still require parenting. And life experience is something that feeds into how well people understand, and not just emotionally, and are able to shoulder the consequences of behavior. What I mean by that is you can have, especially in some societies, a 14-year-old who's actually already helping to supplement the family income, who's actually really independent, is going out and about. And they are actually a lot more mature beyond what their age would suggest than often what we get in a very developed society, which is a young person who is very sheltered, not making any major decisions, still in school, still really dependent. And those issues often are more important than age in terms of determining whether someone is mature enough to make decisions. And finally, and we mustn't forget this, personality and what I call personal style. So you can have very cautious young people versus young people who naturally take a great deal more risk. And emotional development is still in progress. So what we know is that young people are very susceptible to external influences. And I don't mean that in a pejorative sense. This is developmentally normal, and it actually opens young people up to learning more within society. And their ability to appreciate long-term versus short-term can be quite different. A good example is young people, when they learn to drive, we know they have a much higher rate of speeding and accidents and all that. They tend to think they're immortal. They really do. It doesn't occur to them that they might die. And this can actually often influence the way they weigh up things, which is quite key. And emotional states can swing more in young people. Again, that's developmentally normal. And they're often more easily consumed by their emotions at the present. They're more prone to be impulsive. And in my area of work, for instance, you get young people cutting. You get a lot of suicidality, and that's because their emotions are actually very important in terms of dictating some of their behaviors, which can be very impulsive. And when you say to them, why did you do that? They're like, I don't really know. Now, everything I'm saying does apply to adults as well. It's just these are sometimes more exaggerated in young people. Personal style is changing. Value systems are changing. I often say young people are putting on different hats during adolescence. So as a young person, you might be like, one year you're a moody goth, the next year you're being preppy, the next year you're swifty. And that's okay, because that's young people trying to figure out who they are. Decision-making in the middle of all this is not an automatic ability. So every teenager needs the opportunity to practice autonomy. They need to learn to make decisions. And it's usually provided in a normal context by having increasing freedoms as they grow and mature inside and outside the home. But we know they are prone to unwise decisions due to lack of life experience and the tendency to discount risk, which is why, of course, our laws are still very protective for young people. So we're all entitled to make mistakes, adolescents are in particular, because they're not yet experts in living life and making wise choices. And hey, I've made unwise choices, even at my age. So you know what? It's okay. But we're talking about within person factors. No man is an island, and that cannot apply more than for young people. So when we're clinicians, we have to be so aware that we're always working with a system. It doesn't matter who's in the room. There's a system around the young person. This is the way we child psychiatrists think. So around this person, and so whether or not they're present, we have to think about parents or carers or guardians, whoever, the wider family, work, school, other key contacts. And in the adult model of individual treatment, we just think of ourselves and the person. The person can take care of the system around them. But in a pediatric or family model, we tend to have to involve, or at the very least think about, all the more wider people within the family. In child psychiatry, we often involve schools and so on. But I would suggest that actually we are all, as a system, swimming within a wider meta system, which is the law which governs what we do, the healthcare codes of practice, societal norms, cultural, subcultural, and family values, patient and family attitudes and expectations. And all these are influences that impact on all of us in our clinical practice. So it's a kind of formulation that you hold in your head. There's not just me and a young person. So the take-home message is, as long as the teenager is still a legal minor and dependent on the family that they live with, which, for instance, F is, we need to provide those holding parental responsibilities as their carers the information that they need in order to discharge those responsibilities properly, as is their duty. So it's not about parental rights. It's actually about their responsibilities. And in a similar way, schools, clubs, grandparents, anyone who's in the local parentage may have a need to know. Now, the need to know is not from my point of view as an ethicist, not an automatic thing. It's actually about how much is this going to be a case where the young person needs the support of the system, and how much are the people around them providing the system. So that's the sort of basic general thing. I would teach that in the UK. It's going to get more complicated. Here's the warning. So, for instance, this is a quote from someone in Singapore. Sometimes it feels like ethics is linked together with law. On one hand, we are obliged to inform the police if we are informed of something that's statutory rape. On the other hand, we are accused of breaching confidentiality with the threat of being sued by the patient. And then we have our own morals to uphold. So I think that summarizes everything that's just been said. So this is an interplay between law and ethics and culture, our own outlook, what we believe in, our tradition is also playing a part. So there's so many things that are impacting each of these. Now, that sounds like it would apply here. Actually, it's from a focus group I ran with eating disorder teams. But actually what they talked about a great deal is how do you practice in Singapore? That's why I want to share it. It's not about eating disorders. The overarching theme actually that came out of this focus group was the general cultural differences between what they call the West and the Singapore context, and the centrality of the family and the place of the individual in the family. And those are the things I want to share with you. So here's somebody, in our culture in Singapore, I think all three major ethnic races would be very similar with regard to many of us. Even for adults, the parents are heavily involved soon. Still, the Western psychologists and psychiatrists and family therapists would call this enmeshment. They'd be really worried about it. But here it's called filial piety, being a good parent, and so on. So this is the cultural difference. So here, I'm not sure it's reasonable to discuss even with an adult patient exclusively without involving, with the deliberate choice not to involve the parents with regard to his or her recovery plan. Even if the patient is 30-something years old and her parents are 70 or 80 years old. So this is about culture in Singapore. And this person had done some training abroad and said, when I was working in London and Toronto, especially for adult patients, even sometimes with teenager patients, philosophies of those centers is very clear. Whatever the patient says, it's confidential. Sometimes for adults, to the active exclusion of the family in discussing recovery and management. And when the family does approach this, we explain confidentiality. Western families accept it. Coming home to Singapore, it's not so clear-cut. And then the other person said, the other phenomenon is when we try to explain to parents about confidentiality, you cannot know this and that. Sometimes you get quite a strong reaction in Singapore because in our culture, it's anathema to think parents cannot be involved. The parents must not know this. Sometimes they take it as an affront, as an insult, or a form of disrespect to them being parents of the family. That's one stark difference I notice. And then they go on to discuss the generation gap, where young people have much more Western expectations of confidentiality, and the parents don't. So I asked them, I'm interested in how you manage that. The kids more westernized, valuing their privacy, and the parents not. And this person said, I do stress from the start for the younger ones that we do have to involve family, but about confidentiality, I tell the patients that certain things I will keep just between us, certain things I will share. Now, I want to stress this is not about sexual and reproductive health, which does operate generally in slightly different principles, but these are general comments about dealing with the family. And this person goes on to say, if I brought my kid to a psychiatrist, I'd want to know everything. But we have to take the patient's point of view. So I asked, so it sounds like you do buy into confidentiality. Yes, I do. And someone else said, I think sometimes our patients are entitled to have secrets, and families are entitled to have secrets. I think that part needs to be respected. So I said, so it sounds like there's some sense in ethical codes. It's not without merit. Then how do we tropicalize it for Singapore? And I love that sentence because I think that says a lot about the dilemmas of how you work wherever you are. So what's the way forward? And I'm very aware of time, so I'm going to go quite fast. The first thing I would say is we have a duty of care as clinicians. So you have to think about the good outcomes and the bad outcomes. What would a bad outcome look like? I think Subha's talked about that. What would you like to avoid? For instance, is the bad outcome backstreet abortion because you wouldn't do it? Or is it family breakdown because all hell broke loose? We need to be mindful of our duty to promote best interests. What sort of range of good outcomes would you be potentially aiming for? And I think at this point, I want to say the law says this, the law says that, and so on. Yes, it does. But we need to be able to be flexible with the patient around what is the range of things we're exploring with them, rather than deciding, I would do an abortion. No, I wouldn't allow an abortion or anything. That's not for us to say. It is a range of, as it were, least bad options or trying to minimize harm or something like that. So we need to be mindful of medical legal constraints But I would say we do not use them in a rejectful and helpful way. No, can't do that for you. Law won't allow me. Similarly, I would say those questions about what the law says about reporting, we shouldn't use them in a punitive way. We need to be very mindful, and then we need to explain them, and do that negotiation within the consultation. So we need to give F and any similar patients time and space. That's a really key thing. And of course, being 24 weeks pregnant, time isn't on our side, but nevertheless, a dilemma like this cannot be solved in a 10-minute slot. So even if it needs to happen, have follow-up appointments, lots of follow-up appointments where you send her away to think about it, come back, discuss again, and so on and so forth. Keep the communication lines open. Don't come down as, we have to do this, we cannot do that. We need to build a trusting relationship. In fact, F has already given you great trust, and there's clearly a bond because you've looked after her since she was a baby. And that's a trust that has to be treasured, and it has to be looked after carefully. And you need to engage in empathic conversations about the situation, explore her feelings and her wishes. If I was 14 and I was pregnant, I'd be in great distress, very confused. I'd probably be feeling like there was no way out and all that. And those are things you need to hear. And it's totally okay to nudge and to advise young people. That's all part of best interest. So best interest in my mind as a child psychiatrist is not to say, this is in your best interest, so I'm going to do it. It's actually, do you think that's a very wise option? Let's think about whether there's something else we could do. I would advise that maybe this is an option, maybe that is an option, those kinds of things. Let's think through. You're saying you might want to do this. What would happen next? It's those things we need to do. We need to tolerate distress. We need to stay with distress. That's our job. Sorry, guys. That's our job. And we need to get away from our ideas that we have to fix things. We need to understand and explore the family structure and family style. I would suggest, if she's in any way normal, at 14, F can't go it alone if she has a baby. Or even, to be honest, if she has an abortion, because it's a medical procedure, it will have psychological impacts. She will need her parents' support. So discuss this honestly with her and agree a plan. Ask questions like, who's the most supportive person in the family? Who could we bring in to potentially talk to first together? Who's likely to be positive, supportive? And who does she worry about upsetting? Is it someone in the family who would just come down like a ton of bricks with her? I would say involve other disciplines, team members, third sector agencies as needed. There are lots of agencies out there which will advise on options, help to open up the conversation. At 24 weeks, time is short. Organize a family meeting with her and her mother, maybe, to plan a safe and supportive way forward. And sure, I think this is our job as clinicians. We advocate for the patient's wishes and needs. So you need to have explored all those things beforehand. Teenagers are often terrified to tell their parents things, but they are often grateful if we do it for them. So we can discuss ahead of time, I think your mom needs to know this. Would you like me to tell her? What do you want me to tell her? And all that. So it's negotiated beforehand. What about the biological father? And of course, we've already had the question, well, if it's a 28-year-old music teacher or a 14-year-old peer, think with F about that relationship, whether it's exploitative or not, and the future of that relationship. I mean, we got pregnancy now, but F has to live a life after this. So it's something that she needs to think about going forward. Think about providing support avenues and resources. Be part of and advise on creation of a holistic plan for education, medical health, if there's a baby, baby's health and welfare, family, school, social workers, there's a lot of people to get involved. And support F to be a good mother throughout the process. And when I say good mother, I say that irrespective of whether it's a termination, adoption, or she keeps the baby, because she's got this baby in her. So she wants to be a good mother and a good person and someone who finishes the process and goes into the good outcome, feeling good about herself, that she did the best thing. Keep an eye on her emotional and mental health. Yes, I would say that. I'm a child psychiatrist, but it's important. Whatever the choices, this will be severely stressful for the whole family, with a high risk, if she sees the pregnancy through, of both perinatal depression and obstetric complications. So I wanted to finish with some tools, because there's values-based practice where it's about how we have conversations with people about their values, about their wishes. And you have this kind of negotiation. And dissensus is what Bill Fulford talks about. Dissensus is just as important as consensus, knowing that you may not agree about things, but hey, still being able to talk about it, still being able to make decisions. And this is something I and colleagues have come up with. It's based on a concept called cultural safety. This is for team reflection about how do we make decisions? How do we own our own values and then shared values as a team? And how do we work openly and collaboratively with families? And the next one is, I'm nearly there, this is a lot to look at, but it's really a model of cultural safety working with people and their families. It's about addressing power differentials, addressing what our implicit values are, making them explicit, discussing them, talking about trust and relationships and support, and finding a way forward, really. So that's in a chapter that I've published recently. So that's it. Thank you.
Thank you so much, Jacinta. Okay, as you can see from all this, this is the first time I've seen it, the floating emoticons. I think everybody had a good time. But I've got some questions here, as well as a few raised hands. So maybe there are also some questions that have already been diligently answered by Hilary. So the participants, if you can, just go in and look at it. If you have time, we can talk about it too. But if not, then maybe I will ask these questions first. There's a question, I think Suba is trying to type. If the child refuses the termination of pregnancy, but parents insist on termination of pregnancy, what should we do? Maybe Suba, you might want to answer live. You're muted. Yeah, still muted.
Can't see that, but so refusal is always more difficult. But if a child refuses, then I would use that as a status quo. And then you would need to bring in a lot of other people in. However, you need complete information. The child would need assessment. You might bring in a psychologist and all that kind of thing. I don't know, by law, can you refuse? Because can parents refuse? Hilary, you can see that it hasn't been tested anywhere in the area that I work. It's usually It's usually very difficult. Usually we bring in multidisciplinary levels of consultants and specialists, like different, you have to get pediatricians involved in that at that point, and child psychologists, definitely social workers. Yeah, it is very difficult. But just as a summary, I would use the child's refusal as a status quo, and then move from there, and then to see how to go. Yeah. Yeah,
Hillary,
Jacinta. Yeah,
what does the
refusal is
law say?
definitely usually very difficult. Yeah, Jacinta. Yeah.
Yeah.
I do think legally, and I am kind of slightly co-opting Hillary's job, is if they're GILIC competent, then actually they do have a right to refuse things. I think then, I don't think parental choice is always determinative, especially, and I think clinicians become really important then, because we also have input in terms of what we think is in best interests. So I think it is, so I'll shut up in a moment, let Hillary tell us properly what the legal position is. But actually, I would say that's when I would get into a room with all of them and have a family discussion. Because actually it can be a false dichotomy, because parents could be coming from a position where they're really worried about her future and, will it derail everything and destroy her education and her prospects and all that. And the child is saying, I've got this baby, it's moving inside me. I want to keep the baby and I love the baby. And all of them are valid. And it is about, like a values-based practice thing. It's about bringing those threads together, that actually, if the pregnancy is kept, the young person needs to understand that it is going to change the trajectory of her life, and she needs to be thinking about that and dealing with that and maybe grieving the loss of her previous trajectory. And that's okay. It's something we may need to support the whole family with. And the parents would be grieving the loss of that trajectory and their expectations for this bright young person and where she's going in life, So that's part of our role, I would say, to actually support people around the decisions. But I'll let Hillary talk about the law.
Yeah, no, thanks for that answer. And I think I agree with the both of you, especially since you're the ones who are the actual experts dealing with patients in real time and all these complexities, whereas I'm just dealing with it from a very theoretical legal angle. I guess within the Singapore context, because we have a particular statute that allows children to give consent regardless of age, then it's within the child's rights to refuse termination of pregnancy. And in fact, you shouldn't be telling the parents without the patient's consent, because you need to respect confidentiality. There's a legal basis for that in Singapore. But I guess in other places where there's not such a clear-cut legal basis, then it is quite an invasive thing to force an abortion on a young child, especially one who understands what's going on without their consent. So yeah, I completely agree with what Suba and Jacinta has said, that you have to take these additional considerations into account. Yeah.
I'd just like to just highlight that there is a difference between consent and decision. So the client has the right to make the decision. The consent is given, for me, I take it a consent for the procedure. And that's just a consent for the procedure, for surgery, for termination, so that's just the second layer. But the decision is made by the client regardless of age. To me, as a doctor-client relationship, that's the most important. So it's not the parent is making the decision in anything. Ultimately, even if I do see adolescent clients here for anything, my patient is the client. I always tell my junior doctors, do not talk to the parent. Your client is the adolescent, right? Tend to see we will the eye contact is to the parents, or the decision making is that. In my practice, my client is still the number one. The parent sits in the side and understands, and with consent is inside and all that kind of thing. But ultimately, the decision is in the woman who's going to be, subject, or woman or person that's going to be subject to the service. Yeah.
Okay, thank you very much. I've got another written question from Yo Shang Long, who thanks you all for great talks. And basically what he's asking is that are there formal tools or laws to help assess whether the parent is going to further best interest for the child and when to terminate their rights if not, in the context of adolescent sexual health, and whether there should be more such tools? Who would like to take that?
I'm happy to try. I think the first thing I want to do is make a clear distinction between medical treatment and sexual health and reproductive health issues. Of course, the two come close when it's about, say, procedures like termination of pregnancy. But I think the sexual health issues like contraception and all those kinds of decisions are actually more about everyday life as compared to you have an illness and treatment decisions are needed. So I have to say that I come from a background where we are talking about serious mental illnesses and we're talking about medical decisions, which can, of course, happen in pediatrics as well. So I think the thing about the woman's control and right over her own body is something particular to sexual health, although it does reflect the fact that we all should have rights over our own bodies. But I think it's particularly pronounced in sexual health. And so that sort of changes the balance a little bit on what we're talking about. But I think the issue is the clinicians are not neutral. We are being asked to also always discharge our duty of care in terms of thinking about what's best for this young person. What are the safest options? What are, what's not safe? What are the possible consequences of offering treatment or of refusing treatment? So we need to actually take it forward in that sort of way where we're really sensitive about these dilemmas that we face. And it's about trying to negotiate. I think that as a sort of honest broker that we negotiate, but also we should be helping young people. We should be advocating for them, like I said in my slide. If the parents are doing or wanting to do things that are not necessarily in the best interest of the young person, however well-intentioned they are. And so we might be talking about trying to address anxiety and fear and concern. But also, if young people are on a trajectory that we can see is self-destructive, we also have a duty to really advise them. So it is not about there's a simple thing that we're trying to do with them. It's a very complex, almost like a dance. I call it a dance that we do. And we're, to a certain extent, an the orchestral conductor, but we also have a role. It's really, really important, our role. And we are held responsible for what we do in our role.
Okay, we have a few participants who have raised their hands. So maybe I'll ask Go Hai Si, do you want to ask your question? You can unmute yourself. You can unmute yourself now to ask your question. Are you there? Go Hai Si. Okay, if not, the next person in line is Lee Wei Ting. I'll give you, do you want to ask your question? Or maybe they're not asking questions. There you are. Okay. Would you like, you are unmuted now, you can speak. Are you speaking? Lee Wei Ting, we can't hear you. No. Yeah. How about Ravindrang? Do you have a question? Maybe people are using the hand up not to ask questions, is it?
I also see a question in the Q&A.
Okay.
The family unit is a bedrock of our Asian societies. I absolutely agree. Child's interest cannot be explored in a vacuum. Perhaps a family-friendly approach that encompasses the child's interest may be favorable. The doctor can help remind the child and family that their interests are intrinsically linked, and thus decisions should be made that benefits the family as a whole. I couldn't agree more. Because, whatever our involvement is, at the end of the day, this F is still living in a family. And what you don't want to do is disrupt relationships and, sort of have carnage. And then we just walk away saying, I did my job, because that's not our job. Our job is to help the entire family unit. But also to address something that was asked, for us as child health professionals, our main focus is actually the patient being the young person. So, but everything flows from that. So if you think about what I showed, the person in the center, the young person, they live in a system. So it is not contextless. And the immediate system of people around them is further in a system of the society, cultural norms, expectations, and values. And so that's what we have to negotiate. And so it is absolutely the case, and we have to do it differently in the West as compared to in Singapore. But don't misunderstand me. Clinical practice in the West is not as different as you think. Some of the statements might sound different, but for me as a child psychiatrist, I wouldn't dream of not involving the family. Because end of the day, a young person needs their parents. And of course, what's true is the iller they get, the more they need the family. So I think the sexual health, reproductive health issue is a real challenge, because that is usually a private area to the young person. And I think that is the dilemma particular to this one. And then that makes how much we use the parents as the decision makers more tricky.
Okay, thank you. I think this next question is for Hilary. In the legal context, in considering the situation of the teenage pregnancy, do we include the unborn child as well as the teen and her parents?
So this is a great question. In the common law world, a fetus doesn't have any legal personhood until born alive. So that just means that the fetus has less legal rights and compared to a legal person or an adult or the mother in the circumstances. And that means, so we don't consider the fetus in the same way. But of course, ethically, people might have different stances on that issue. Do any of the other panelists want to add to that?
No, I totally agree. Yeah.
Okay, I think Prof. Roy Joseph has a question. Prof, you can unmute yourself.
Thanks for a wonderful time. Jagdish, would you like to share what happened to F finally?
Yes. F finally had to continue with her pregnancy because there is no scope in India for an abortion beyond 24 weeks. So then the next thing is that there is a law which in India called the POCSO Act, which is primarily meant for the adolescent sexuality. And there is a lot of debate going on on whether the age of consent should be brought down from 18 to 16. But as of now, unless there is a gross danger to the life of the mother, an abortion beyond 24 weeks is not allowed. And some cases are there where the court has allowed termination of pregnancy when it comes out of rape. And there they have extended the abortion up to 28 weeks. But again, these are very exceptional cases. It is only up to 24 weeks that it is allowed.
You have a question too, right, Jagdish? You wanted to ask the panelists.
Yes. This is to the panelists. wonderful discussion. But does the partner have any rights in this matter of deciding on termination or not? Does he have any rights on the unborn child? I think maybe I should address this to Hilary, because it seems to be a legal issue.
That's a great question. I think somebody else in the chat also raised something similar. The short answer is that I have to look more into it because I'm not a criminal lawyer. So yeah, I definitely have to say more. But then by right, the patient is the one that that you're treating and that you owe a duty to. So it would be very difficult to imagine like the partner coming in and trying to force his way over the decision, because that might be considered a form of undue influence. Yeah.
And definitely, I think termination of pregnancy laws across the world do not give any, right to the partner. Yeah. So far, the consent has to be from the woman themselves. Certain countries do request consent from a partner, but that's just an extra consent. Yeah.
I think it's an interesting moral dilemma, but I think legally, until the baby is born, the biological father doesn't particularly have any rights. So I think it's then a question of how much the woman wishes to include the man. So, if you're married and you want to include the husband, you can. But in fact, married women, I think, are actually the biggest users of termination of pregnancy and don't necessarily involve their husbands. But I did raise the issue of what about the biological father, if you remember my slides, because I think that's something that should be discussed with any mother, not in the sense of you must involve him, but actually what's going to happen with this relationship? What do you make of it? And also actually, as child health practitioners, determining whether we think there's a child protection issue there. So, if it's her 28-year-old music teacher, what we talked about, and whether it's actually an exploitative relationship, if it's something where she was groomed online and all that kind of thing, there's a lot of alarm bells that should ring in that case. Whereas if it's, a peer in her class in school, that's a very different kind of thing. And it is about then exploring what it is and what her wishes are, and actually thinking with her about what happens to this relationship going forward, because it's going to change the relationship. And, I imagine also negotiating with the parents, her negotiating with parents, what happens with the relationship, because I can well imagine they'll have thoughts about that. So there's a lot of issues that she has to kind of work her way through, which are not easy at all. And I think it is part of our role to help negotiate all those relationships going forward.
Okay, I'm very aware of time, but I think I'd like to ask this last question on behalf of Zainul. And he was saying, would gender-changing procedure, which will change the adolescent sexuality and reproductive function irreversibly, be subject to the same legal precepts and discussions?
I'm happy to take on that question. Others can jump in as well if you have some thoughts. So this is, we could have another seminar just on this particular issue, because it's a very fraught and complex issue. So even looking at the English context, they've recently decided that puberty blockers will now only be available as part of research. And there were previous age thresholds, like only allowing cross-sex hormones to be prescribed from 16 onwards, and gender reassignment surgery to be performed from the age of majority onwards. But even that is in a state of flux, where, there's still emerging evidence on this and debates occurring on this issue. In the Singapore context, we don't have any specific guidance on this. So this is something where we just have to KIV and probably seek legal advice on this specific issue if you're unsure.
Can I just jump in? So I provide gender affirming care. I'm one of the few gender friendly clinics, and I do provide transitioning hormones to children. But then like they would follow the same principles, overarching principles of consent, of best interest of the child, of involving the confidentiality, of involving the parent. The child age of majority in Malaysia is 18, so we would definitely involve the parent. But it is like Jacinta said, you have to understand the whole process. It is a developing area of work, but I see that as any other facet of healthcare. I'm very against, just specifically, just zoning into gender affirming care, because gender affirming care should be as anything, and termination of pregnancy should be as boring as removing a tooth, if you ask me. But the principles of how we provide services, of the best interest of the child, of the position of the parent, and all that, the issues that govern the approach to care should be the same. Yeah. So in a whole, it's the same, but definitely it's an evolving issue. Yeah.
Okay, thank you very much, all our speakers. I realized I didn't let your re-poll, but I thought we will have more time for question and answer. So thank you very much for all our participants who stayed till the end. We would like to have a little feedback. So if you could just spend a few minutes to feedback on the Athena, because we are hoping that this is going to be something that can be done regularly. Please do give us your feedback, and also give us suggestions on what other topics that you would like us to organize. Was it the okay? And also, if you are again interested to know more about the Asian Pediatric Ethics Network, and also to want to sign up to be on the mailing list so that we can let you know, especially about our upcoming Asian Pediatric Ethics Conference in Singapore on the 6th to 7th of November, please do use the QR code to sign up, and we will be pleased to see you there. Otherwise, thank you so much, everyone, for attending this Athena. I hope you found it useful as I did, and hopefully that you would be able to participate in all the other events that we organize. Thank you very much. Sometimes 1, 2, 3. But they can hear.
We still got 100 people in.
Also can read it. Okay. 1, 2, 3. Okay, we are gonna take a photo. Okay. 1, 2, 3.
Okay, thank you.
Okay, thank you very much, everyone.
I enjoyed that. Thank you very
Yeah,
much.
I had messages from people saying
Jacinta,
that the talks are
Hillary,
really useful.
Project.
Thank you so
Yeah.
much.
Thanks, Mayo.
Thank you very much.
Yeah,
Okay,
thank you,
bye.
Mayo, for organizing. And thanks,
Thank
everyone.
you. That was really enjoyable. Bye.
Okay, great. Thanks. Bye, everyone.